Hi everyone, this lesson is on the different types of aphasia. So what is aphasia? Aphasia is an acquired cognitive condition involving reduction, disruption, and or loss of ability to speak. There's going to be a lot of important characteristics with regards to each type of aphasia, and we're going to get into those more specific details later on when we talk about each type. And aphasia ultimately is due to injury to language areas in the brain. It's either going to be direct injury to those language areas or surrounding areas. Now, there are a variety of causes of aphasia, and essentially they are any insult or injury to the brain areas containing language centers. So some of these are going to include trauma. So if there's head injury or a head trauma to those particular language centers, that's going to be one particular cause. Another very important cause is going to be a stroke or cerebrovascular accident. So this can either be an ischemic or hemorrhagic stroke that affects those areas of the brain that are involved in language. We can also see it from a brain mass. If there's a particular type of brain cancer that is starting to grow in those particular language areas, that can also cause aphasia as well. We can also see it in certain neurodegenerative diseases. This can include vascular dementia. We can also see it in cases of Alzheimer's disease and frontotemporal dementia as well. And then the last cause I want to talk about here is encephalitis. So encephalitis is going to be inflammation of the brain, often due to some infectious cause. So these are all going to be important causes of aphasia. Now, although we didn't talk about where these language areas are located in the brain yet, the epidemiology shows us where the language areas are going to be in the majority of patients. So 90 to 95% of cases of aphasia involve brain injury to the left hemisphere. So we're going to talk about where exactly these language areas are located in the brain in the next slide, but we can see that a majority of patients have the language centers in the left hemisphere. It's also important to note that a third of cases of aphasia are due to a cerebrovascular accident or a stroke. So stroke is going to be a very important cause of aphasia. And then the prevalence of aphasia increases with increasing age because these types of causes increase in prevalence as a patient ages. So for instance, a stroke or a brain mass or other neurodegenerative diseases, we're going to see the prevalence of aphasia increasing with increasing age because of the increased prevalence of these other conditions we just mentioned. Now let's talk about the anatomy and where the language areas are located in the brain. So the language areas of the brain are actually associated with the handedness of the patient. So this is why when a patient does have a stroke, for instance, the clinician is going to ask, what is their dominant hand? Because this is going to help indicate whether or not the language centers are going to be in the left hemisphere or the right hemisphere. So for instance, right-handed individuals are going to almost exclusively have their language centers in the left hemisphere. So greater than 99% of right-handed individuals are going to have their language centers in their left hemisphere. So because right-handed individuals make up the majority of the population, and the vast majority of right-handed individuals have their language centers in the left hemisphere, this is why we see 90 to 95% of aphasia cases involving the left hemisphere. But what's interesting is when we look at left-handed individuals, the location of the language centers in left-handed individuals is going to be more varied. For instance, 70% of left-handed individuals are going to have it in their right hemisphere. So this is very interesting. We see that left-handed individuals, majority of them are going to have it in the right hemisphere. It's going to be on the opposite side. But in 15% of left-handed individuals, it's going to be in the left hemisphere. It's going to be the same as those right-handed individuals we talked about before. And then the other 15% are going to have it bilaterally. They're going to have it in both hemispheres, both right and left hemispheres. So the language centers are going to be shared between both hemispheres. So very interesting. So if we look at the brain, here is the right hemisphere and here's the left hemisphere. So again, as I mentioned before, the majority of patients are going to have it in their left hemisphere. So when we actually look at the brain and the left side, we can see two very important areas of the brain that are going to be important in language. One of them is known as Broca's area and the other one is known as Wernicke's area. And we're going to talk about these in more detail in the next slide. Before we actually get into looking at those particular language centers, let's look at an overview of the brain itself, because we're going to need to know the different lobes in order to better understand where those language centers are located. So the brain has four lobes: the frontal lobe, the temporal lobe, the parietal lobe, and the occipital lobe. And what we're going to see is that the language centers are going to reside in the frontal lobe and the temporal lobe. So we can see more specific details of the brain in this schematic here. So again, frontal lobe, temporal lobe, parietal lobe, and occipital lobe. And here's another image of the brain showing Broca's area and Wernicke's area. And these two language centers are connected to each other, and we're going to talk about that connection here in a moment. Let's first talk about Broca's area. Broca's area is located in the posterior inferior frontal lobe. So if we were to look at the brain, this is the anterior of the brain, or the front, toward the front, and this is the posterior toward the back. Here is the inferior aspect of the brain, and here's the superior aspect. So Broca's area is in the posterior inferior frontal lobe. So this is the frontal lobe here. It's going to be in the posterior part of the frontal lobe and the inferior part. So it's going to be located in and around this area here. Broca's area is involved in initiating speech, motor control of spoken language, and sentence formation. So it's very important for controlling speech output. Moving on to Wernicke's area. Wernicke's area is located in the posterior superior temporal lobe. So here is the temporal lobe here in this area. It's going to be at the more posterior aspect of the temporal lobe, and it's going to be superior. So it's going to be located in this area here. Wernicke's area is involved in understanding spoken language and planning use of words. It's involved in comprehension, so it's going to be very important as well. And then another important part of the brain is going to be the angular gyrus. So the angular gyrus is going to be located in and around the Wernicke's area. So it's going to be adjacent to Wernicke's area. It's involved in understanding and relaying written language to other areas of the brain and comprehending words. And another very important structure for language is the arcuate fasciculus. So the arcuate fasciculus is going to be a neuronal bundle or connection that connects Broca's area and Wernicke's area. So connects Wernicke's area and Broca's area. So these are the structures of the brain that are impacted in various types of aphasia. Let's talk about the different types of aphasia. So one is known as nonfluent aphasia. Another one is known as fluent aphasia. Another one is known as global aphasia. Another one is conduction aphasia. Another one is transcortical aphasia, and this is broken down into a few different types of transcortical aphasia we're going to talk about in a moment. And the other one is anomia or anomic aphasia. So with non-fluent aphasia, this is also known as Broca's aphasia or expressive aphasia. And the reason it's called Broca's aphasia is because it involves a lesion to Broca's area. Fluent aphasia is also known as Wernicke's aphasia or receptive aphasia, and it involves a lesion to Wernicke's area. In global aphasia, it's essentially both Broca's and Wernicke's aphasia. Global aphasia is going to often be due to a large lesion that's going to encompass parts or the whole of both Broca's and Wernicke's areas, or it can often run along the middle cerebral artery. This is going to be the most common and most severe type. Conduction aphasia is a lesion that may affect the area between Broca's and Wernicke's area at the arcuate fasciculus. So that connection, that neuronal bundle that connects Wernicke's area and Broca's area is going to be affected in conduction aphasia. And then transcortical aphasia is going to be broken down into transcortical sensory aphasia, which is a lesion that's located around Wernicke's area but does not include it. So the lesion is going to be in the structures around Wernicke's area. Another type of transcortical aphasia is transcortical motor aphasia, which involves a lesion located around Broca's area but does not include it. And then there's mixed transcortical aphasia, which is a lesion located around Wernicke's, Broca's areas, and the arcuate fasciculus. So it can be a mix depending on where the lesion occurs. And anomia or anomic aphasia is a lesion that occurs at the angular gyrus. So that was a lot of information, but let's move on to the clinical features of aphasia. We're first going to talk about non-fluent aphasia. Again, this is also known as Broca's aphasia or expressive aphasia. So the problem with non-fluent aphasia is in the word non-fluent. And if we think about what we talked about with regards to Broca's area, and Broca's area is involved in initiating speech or motor control of speech, we're going to have issues talking. We're going to have issues speaking words. So in non-fluent aphasia, we're going to have good language comprehension. The patient's going to understand what's spoken to them, but they're going to have issues with speaking in general. They're going to have a lot of trouble talking, getting their point across. They're going to have a lot of hesitations in their speaking. And then if you try to get them to repeat or name certain objects, they will also have issues with this as well because they have issues speaking in general. Non-fluent aphasia patients have poor grammatical speech and poor ability to write, so even though they understand what's spoken to them, when they try to speak, it's very broken. Their sentences are broken. But interestingly, the main idea that they're trying to speak is often able to be conveyed. It's just the sentence is often broken. And paraphasias in this type of aphasia are uncommon. You might be wondering what paraphasias are. Paraphasias are when a patient incorrectly substitutes one word for the other. There are actually two types of paraphasias. One of them is semantic paraphasias, where the patient substitutes a word with a similar contextual meaning. So this could be substituting table and chair, for instance. Or the other type of paraphasia is phonemic paraphasia, where this is when the patient substitutes a word of similar sound. So they might say nine and nice, for instance. Those might be a paraphasia they may use. Let's move on to fluent aphasia. So fluent aphasia, again, is also known as Wernicke's aphasia or receptive aphasia. So we learned what Wernicke's area is involved in. It's involved in comprehending speech or understanding spoken language. So because Wernicke's area is affected and Broca's area is not affected in fluent aphasia, so Broca's area is again the initiation of speech, they're going to have good spontaneous speech. But I put in quotations good because they're going to talk a lot, but it's often going to be words that have no meaning. So it's often going to be meaningless speech. And because Wernicke's area is involved in comprehension, they're going to have poor comprehension of both spoken and written words. And they may use numerous neologisms. Neologisms are when they make up new words. And both types of paraphasias are common in fluent aphasia. And these patients are going to be unaware of their mistakes, so they're going to make many errors. They could say many different paraphasias, make up new words, say a lot of words that have no meaning, and they will not recognize their mistakes. They will not try to correct their mistakes. The next one we're going to talk about is global aphasia. So global aphasia is going to, again, involve both Broca's and Wernicke's areas. So because it involves Broca's areas, we're going to have poor spontaneous speech. They're not going to be able to initiate speech properly. And because they also have issues with Wernicke's area, they're going to have poor language comprehension as well. And because they have both of these, they're going to have poor repetition and naming. And they can often be unable to read or write. Because of all of these, this is the most severe type of aphasia. The next type is conduction aphasia. So conduction aphasia, again, involves a lesion or an injury to the arcuate fasciculus, the neuronal bundle connecting Wernicke's area and Broca's area. So Broca's area is intact, meaning that they can speak, they have spontaneous speech. Wernicke's area is intact, so they have good language comprehension. So you might be wondering what happens when the arcuate fasciculus is affected. Well, this is actually where we start to see issues with difficulty or inability to repeat. So they can speak, they understand what's spoken to them, but if you get them to try to repeat something that you just said to them, they won't be able to, or they'll have a very difficult time doing that. And they can also have phonemic paraphasias as well. But because they understand spoken language, they will recognize their mistakes and try to correct them. Now, moving on to the transcortical aphasias, the first one we're going to talk about is transcortical sensory aphasia. Remember, this is a lesion around Wernicke's area, but not involving Wernicke's area. So you might be wondering what happens here. So because Broca's area is not involved, we see good spontaneous speech. But because they have some areas around Wernicke's area, they can have some difficulty or inability to comprehend. They may have some ability to comprehend, but they will have some difficulties as well. But they can repeat fluently. So if you were to get them to try to repeat something to you, they will repeat it to you. And then in this type of aphasia, we can see semantic paraphasias being common. The next aphasia we're going to talk about is transcortical motor aphasia. So again, this involves lesions or an injury around Broca's area, but not involving Broca's area. So they're going to have a milder form of Broca's aphasia. So they're going to have non-fluent speech, but they may be able to speak 1 to 2 words. So it's going to cause a non-fluent speech like Broca's aphasia. And because Wernicke's area is not affected, they're going to be able to comprehend. If you talk to them, they're going to be able to comprehend you. And they're also going to be able to repeat long and complex sentences. This is going to be different than Broca's aphasia, where Broca's aphasia patients are not going to have the ability to repeat, or they're going to be very poor at repetition. But with transcortical motor aphasia, they're going to be able to repeat long and complex sentences. This is going to be the difference between Broca's aphasia or non-fluent aphasia and transcortical motor aphasia. But these patients will also have issues with naming. And then mixed transcortical aphasia is going to be lesions in and around Broca's, Wernicke's areas, and the arcuate fasciculus. So they're going to often have poor fluent speech, poor comprehension, because the lesion is going to be around Broca's area and around Wernicke's area. But they're going to be able to repeat long and complex sentences. And they're going to have issues with naming. So mixed transcortical aphasia is going to be like a global aphasia, but instead of global aphasia patients that have issues with poor repetition, these patients are going to be able to repeat long and complex sentences. So we can see analogs with each of these types of aphasia. Transcortical sensory aphasia is going to be like Wernicke's aphasia, but they're going to be able to repeat, unlike Wernicke's aphasia. Transcortical motor aphasia is like Broca's aphasia or nonfluent aphasia, but these patients with transcortical motor aphasia are going to be able to repeat long and complex sentences, unlike Broca's aphasia patients. And then mixed transcortical aphasia is going to be like global aphasia, except these patients will be able to repeat as well. So that's going to distinguish between those other types of aphasia we talked about before. And then the last type of aphasia is anomia or anomic aphasia. This is involving a lesion around or at the angular gyrus, and it may involve lesions in other parts of the brain as well. So these patients are going to have a particular problem. Because they have Broca's area, they're going to have good spontaneous speech. Because they have Wernicke's area, they're going to be able to comprehend. They're also going to be able to repeat. So you might be wondering, what problem do they have? Well, the problem they have is that they will have what is known as word blindness. So they will not be able to think of words properly. They'll have difficulties finding words. So they're going to have poor naming. This is the only issue these patients are going to have. So again, this is going to be a less severe form of aphasia where they only have the issue of poor naming. So here is an overview of the different types of aphasias. We break it down into two main categories, nonfluent and fluent, and then we break it down further depending on whether or not they have poor or good comprehension, poor or good repetition, and whether or not they have poor or okay naming. As we will see, most of the conditions have issues with naming. So if you want to go over this would be a good way of summarizing the different types of aphasia. Some other clinical features of aphasia include agraphia and alexia. So agraphia is going to be an inability to write. Alexia is going to be an inability to read. This can occur in all types of aphasia. And the severity of symptoms that we talked about before is going to depend on the severity of the injury or lesion. And depending on the underlying cause of the aphasia, we can see other types of signs and symptoms. For instance, if it's due to encephalitis, we may see a fever, headache, and altered mental status. If it's due to a type of dementia like Alzheimer's disease, we can see issues with cognition and memory. And if it's due to a stroke, we may see focal neurological deficits. And having said all that, there are particular other conditions and other categories of conditions that can have similar symptoms. So they may have issues with speech or understanding speech, but they're not going to be classified as aphasia. So these disorders that are going to be excluded that are not aphasia include developmental disorders. So if a patient is born with an inability to speak or an inability to comprehend speech, this is going to be a different disorder. Another category of disorders that would be excluded would be motor speech disorders. So if it's a disorder that is limited to being able to speak, that is not going to be the same as an aphasia. And then if the language problems are secondary to a primary psychiatric disorder, this is also going to be excluded and not considered aphasia. And some of these may include schizophrenia, for instance. Let's talk about how clinicians diagnose and treat aphasia. So the diagnosis is going to be a clinical diagnosis. It's going to be from history and physical examination. So what's often going to be very important is going to be a cranial nerve exam and assessing for any signs of stroke. Imaging can also be important as well, can help determine whether or not a patient had a stroke. So a CT scan of the head can be important, MRI, and a carotid ultrasound. Carotid ultrasound is going to be used if there is a worry of carotid stenosis that may have caused the stroke. And imaging can also help to diagnose if there's a brain mass or if there's Alzheimer's disease, for instance. And then blood work may be performed in some cases if there is question as to whether or not a patient has encephalitis, for instance. So the treatment of aphasia is going to be often supportive. So what's going to be the mainstay of treatment for aphasia is going to be speech and language therapy, very important in helping to recover some of the lost language skills. Other treatments, again, depend on the underlying etiology. If it's a stroke, acute stroke treatment is going to be important. Beta blockers and anticoagulants may be used in the case of atrial fibrillation that may have caused a stroke. Surgery may be a treatment if there's a brain mass. Antiviral treatments may be used in the case of encephalitis. So if it's herpes encephalitis, we can use acyclovir. So that could also be used as well. And then resolution or improvement of symptoms may occur in some cases. If the patient is younger, if the lesion is smaller, they're more likely to recover all of their function. If they're more healthy, if they have less health problems in general. If they're left-handed, they may have better outcomes as well. So if they're left-handed, they may have a bilateral localization of their language centers that may increase the likelihood that they have better outcomes. So if you want to learn more about other types of neurology conditions, please check out my neurology playlist. And if you haven't already, please like and subscribe for more lessons like this one. Thanks so much for watching, and hope to see you next time.